Muhammad Syahrir Muhammad Said, Senior Consultant Rheumatologist in Department of Medicine. The second panelist is Associate Professor Dr. Rosita Muhammad, Consultant Nephrologist in the Department of Medicine. The third panelist is Associate Professor Dr. Rabani Ramli, Consultant Neurologist. And last but not least, Associate Professor Dr. Nora Shikin Yusof, Consultant Hematopathologist from the Department of Pathology. Okay. So without further ado, I would start the case presentation. Okay. So I would like to invite Dr. Izrina to present on the case.
Assalamualaikum and very good afternoon. So I'll be presenting on our case for today, a young woman with headache. Right, so this patient, she's a 32-year-old woman, presented to clinic with severe frontal headache for 2 days associated with vomiting. There was no fever, photophobia, blurring of vision or limb weakness associated with it. On physical examination, her GCS was full and pupils were equal and reactive. Her blood pressure was normotensive, 130/80. Pulse rate, not tachycardic, was 88 beats per minute and afebrile. There was no neck stiffness or any neurological deficit noted. Other systemic examination seems to be unremarkable. The past medical history was also not significant. So we proceed with the initial blood investigation. As you can see from here, we have the FBC, renal profile, and liver function test. So the only abnormalities noted from this initial blood investigation is the finding of thrombocytopenia, with FBP showed a platelet count of 20 over a high power field. And also there's hypoalbuminemia of 25, albumin 25. Otherwise, the other blood parameters seems to be normal.
Okay, Izrina, so at this point, can you tell us the differential diagnosis based on the history and investigations that you have presented, and what investigations would you perform at this juncture, and the initial management of this patient?
Right, so thank you, Prof. Rafia. So basically, the differential diagnosis for this patient, young lady came in with symptoms of increased intracranial pressure. So number one diagnosis that I need to rule out is intracranial bleeding. That's number one. The other differential would be infective causes such as viral meningoencephalitis, and I also need to rule out space occupying lesion in this patient. So further investigation for this lady, apart from the initial blood investigation, need to proceed with initial imaging lah. So we need to do a CT brain to rule out the differential diagnosis that I have mentioned, as well as after reviewing the CT brain, if there's no indication, we'll proceed with lumbar puncture to get further information from it. In terms of the initial management, as I mentioned in my differential, viral meningoencephalitis would be one of the, one of the things that I would consider. Depending on the lumbar puncture results, if it's indicative, that I would start acyclovir 500 mg TTS for the patient.
Okay, thank you, Izrina. Okay, so at this point, okay, so Prof. Rabani, okay, can you tell us the general approach of a lady with headache, and how do you differentiate whether this is a benign pathology or something significant pathology of headache?
Right. Thank you, Prof. Rafia. I think headache is a very common encounters for doctors in clinical practice. Of course, in neurology practice, we have receive a lot of referral of a primary headache to rule out secondary headache. So there are mainly two important questions that you have to ask yourself whenever you have a patient referred for headache. All right. So one, you have to differentiate whether this is a primary headache or whether or not this is a secondary headache. How can you differentiate? It's mainly based on a clinical history. All right. So most of the headache diagnoses are entirely from the patient history, and whenever you examine the patient, very rarely you will get to to have some neurological deficit, especially in primary headache. And another question, important question that you have to ask, whether or not is there any red flag signs. All right, so it is a very simple mnemonics that you can, that can inform to you. It's actually SNOOP mnemonics, all right? One is systemic signs or disorders, one of the red flag signs, whether or not the patient has neurologic symptoms, whether or not this is, the onset of headache is new, all right? And whether or not the onset in a thunderclap presentation that commonly you see in subarachnoid hemorrhage, or whether or not there's any clinical evidence of papillary edema for P, all right, and whether or not there's any pulsatile tinnitus in the history that you can get from the patient. So whenever you, mainly in primary headache, is there any slide here? Okay, all right. So this is basically approach to headaches. So as I mentioned to you, one important question you have to ask whether you have to differentiate whether this is primary or secondary headache, and is there any red flag sign? So if you can answer these two questions, then I think you can manage this case, effectively. So next slide. So mainly when you have to differentiate whether this is a primary headache or secondary headache. Okay. So primary headache are basically the commonest headache that you see in outpatient clinics. Like migraine, which is a unilateral throbbing headaches that are associated with nausea, vomiting. They can have prodromal symptoms. They can have aura. Some patients can have prodromal of confusion. So these are the things that you have to get from the history. So typically they are unilateral throbbing headache. It can be very severe. Okay. In tension type headache, they are usually a band-like tightening over the forehead, and they tend to be boring type of headache. Okay. So and they're usually recurrent attack. Okay. So and there's also another primary headache that you should not miss, which is a cluster headache. In clinical practice or in neurology practice, cluster headache is actually not very common in Malaysia. All right. So importantly about secondary headache is actually when you identify the red flag signs, okay, the SNOOP mnemonic, then you should be able to go through few differential diagnosis of secondary headache. Like I think in this case, like that we are discussing today is actually a young lady with onset of